Hemochromatosis. Hemochromatosis is a disorder in which extra iron builds up in the body to harmful levels. This buildup can affect the skin by changing it to a more bronze color. It can also affect the heart, the pancreas, and more notably, the liver. When left untreated, it could potentially lead to diabetes, heart problems, liver damage, and even liver cancer. In the liver, iron levels are controlled by the hepcidin regulatory pathway. It can be said that anything that disrupts this pathway can lead to hemochromatosis. Hepcidin is a negative regulator for iron absorption. There are four main types of hemochromatosis, each affecting the hepcidin regulatory pathway. Type 1 is associated with the mutation in the HFE gene. Type 2 is affected by the mutation in the HFE2 gene. Type 3 is caused by changes in TFR2 gene. And type 4 is caused by changes in the CLC40A1 gene, which makes it autosomal dominant, whereas the other types are autosomal recessive. We will focus on type 1 hemochromatosis in this presentation. Mutations in the homeostatic iron regulator, or HFE gene, in chromosome 6 is what leads to type 1 hemochromatosis. At low plasma iron concentration, HFE is bound to TFR1, therefore signaling the hepcidin to remain silent. While at high concentrations, HFE is released and signals for enhanced hepcidin production. So when it is mutated, it is unable to detect high iron levels, thereby decreasing the production of hepcidin. It is important to note that there are multiple mutations that can happen in these genes, and a few of them are listed below. Some of them are more hazardous than others. One of the most common mutations is an amino acid change at position 282, changing it from a cysteine to a tyrosine, or the C282Y mutation. The mutation causes the loss of a disulfide bond, which interferes with the interaction of the HFE protein with the beta-2 microglobulin. Because of this mutation, the C282Y mutant protein has decreased presentation at the cell surface, increased retention in the endoplasmic reticulum, and accelerated degradation. In other words, its original function is severely inhibited. The C282Y mutation dates back about 6,000 years ago among ancestors of the Celtic population. As a result, people with Northern European descent are more likely to develop the disease. It is estimated between 1 in 200 to 1 in 400 persons of Northern European ancestry is a C282Y homozygote. Something interesting about hemochromatosis is that men are 2 to 10 times more likely to develop hemochromatosis than women. Because women menstruate, they naturally lower their iron levels every month. Typically, the only time a woman starts displaying symptoms of hemochromatosis is after menopause. Diagnosis. Common symptoms of hemochromatosis are changes in skin color, enlargement of the liver or spleen, tenderness in the abdomen over the liver, and tenderness and swelling in the joints. Hemochromatosis can be diagnosed by blood tests, where they test your iron levels, levels of transferrin, and levels of ferritin. By testing these levels and ratios, they can determine how much iron is in the blood and how much iron is being absorbed in the liver. Another way to test for hemochromatosis is through genetic testing, where they test for the common genes that are responsible for the disease, like we discussed in previous slides. Finally, a liver biopsy can be done where they take a sample of liver tissue and stain it for iron, which will show whether too much iron appears to be present. Something to mention regarding hemochromatosis is that many people don't realize they have the disease. Also, if they do have the mutations, it doesn't necessarily mean that they will develop hemochromatosis. Treatment. There are 3 ways hemochromatosis can be treated: phlebotomy, changes in diet, and medicine. Phlebotomy is the most common treatment, which is essentially blood donation. By regularly donating blood, iron levels can be brought back down to normal. Blood donated by patients with hemochromatosis can be used because hemochromatosis is not a transmissible condition. Therefore, other individuals who might receive this blood are at no risk of developing iron overload. One drawback to this treatment is that it must be carried out throughout the patient's lifetime in order to maintain stable iron levels. The second treatment of hemochromatosis is the diet. A person diagnosed with hemochromatosis must avoid food with high levels of iron, like red meat, beans, eggs, poultry, nuts, and dried fruit. There have also been studies to see which food can actually precipitate iron out of the body. Polyphenol-rich dietary sources like black tea powder, cocoa powder, and grapefruit extract can effectively precipitate iron in vitro, which decreases iron absorption. The third treatment of hemochromatosis is chelation therapy. Chelation therapy is a similar technique to the polyphenol-rich food, as it uses special drugs that binds to metals in your blood, but with more efficiency. You get the chelating medicine through an IV in your arm. It is also available in pill form. Chelation is sometimes used with people who have iron overload but cannot undergo phlebotomy because they have anemia. However, because phlebotomy is more simpler and a possibly more effective treatment because it affects the potential side effects of chelation drugs. Overall, there is much to be done regarding hemochromatosis in the future, especially as our knowledge of human genetics grows. This has been an interesting disease to study as my dad has this condition, and I had the wonderful opportunity to talk to him about his experiences with it. Thank you for listening.